So I'm just going to hold it. Okay. I'm just going to hold it then. Not to get snazzy, but that's all right. We're going to make this work. So welcome everyone, and we get the privilege of having you after lunch, which is fun. So hopefully you'll have coffee with the lunch. But we're going to make it so interesting that you're not going to fall asleep over, right? So that's our pressure. All right. So welcome to the panel. We're going to talk a little bit today about care at home. What has been interesting over the last several years, now a little bit over a decade, is we started to see the locus of care move more and more to the home. We started, this decade, or last decade actually, with a lot of programs with the promise that chronic care management can happen at home, and we told these patients to show up in the hospital all the time in outpatient settings. Over the in the last decade, we saw that the locus of care started to move more also in the inpatient setting. The last 3 or 4 years have seen a lot of innovation around hospital at home as another care model, where we're starting to move the locus of care to the home, even from inpatient and emergency medicine settings. And this movement has been really interesting. For example, about 100 organizations today have adopted hospital at home programs in some form. And that's a pretty large number if you think about an innovation that is sort of starting to hold ground. Obviously, COVID and the tailwinds resulting from COVID have helped with that a lot. But what we're going to do is unpack a little bit of that today as well and talk about what has led to the explosive growth that we're seeing and what can we do to keep that growth consistent and going. On the other side of the growth that we're seeing, we're also seeing challenges that care at home models are riddled with. Some of those include challenges at the front line workers. Some of those include challenges with patients and patient engagement. Some of those include challenges with the infrastructure that we need from a technology standpoint, as well as from a reimbursement and a regulatory standpoint. So we're here to talk about how can we figure out a way to make care at home safe, effective, scalable, and successful for our providers and our patients. And that's our challenge for the next 55 or so minutes. I'm going to turn it over to my panelists to sort of introduce themselves. All of them represent a different vertical or a different perspective in the care at home puzzle. We're going to talk about what care at home models you're engaged in and what your perspective is on where care at home is going from your particular vantage point. We have a very stellar panel here, and I'm looking forward to hearing from them. And then before I turn it over to them, as Ritesh mentioned, there is a handout in your packets which sort of explains the entire hospital at home movement and what hospitals and vendors should be thinking about in the hospital at home implementation side. So that's in your packets as well. So without further ado, we'll get started with Perry.
Thank you. Perry Abitan, CEO, founder of LifeCare. LifeCare developed two major components that contribute to care at home. One is a patient engagement solution, which is called the Link Plus. It's a smart home medical gateway. 3 years in the market, close to 50,000 lives on it. And the second part, which is a provider engagement tool. And today we actually announced a launch of a new tool called Clini, which I'll speak as we go. But to summarize, virtual practice management platform.
I'm Diana Gelston. I'm the Chief Commercial Officer of Decimal.health. And our goal is to enable care at home for everyone. And we do that through having access, easy access in a Best Buy store, where 75% of the population lives within 10 miles of a Best Buy store, to buy a hearing aid, to buy a blood pressure cuff, to buy an SpO2 device, so wellness at home. Aging at home, we have a portfolio of solutions. We've been in healthcare for over 6 years because people ask, Best Buy, that big blue store with a yellow tag, what are you guys doing? And we procured in the past 6 years about $2 billion in companies that really focus on wellness at home. So I just spoke about that. Aging at home, which is the jitterbug phones you may have heard about, the lively phones, to really focus on making those connections between a person, because they're not a patient, a person in their home and their loved ones, as well as our caring centers to help support them and be successful in their journey. And then we also purchased a company called Health over a year ago that is focused on, they started in the hospital at home space, and again, there's a great briefing about hospital at home in the packet. And then we've moved really down the scale of acuity to transitional care, post-acute care, and chronic care at home, and building a one enterprise platform that connects the patient who is at home, it's a person in their home, of course, with their health system and their physician. So that's what we do every day.
Great. And before we move ahead, I would request if we could hold our mics. It's been a little bit hard, I think, at the back, just to be easy. All right.
All right, can everybody hear me? Perfect. So I'm Vimal Mishra. I'm an insider. I'm one of the practicing physician at UC Davis Health. My practice is generally inpatient and consultative medicine, inpatient side. But in addition, I wear two hats. One hat with UC Davis Health as a VP of digital care, where I am responsible with my operations partner, who is in the audience here as well, for care at home, for digital monitoring, supporting population health, supporting virtual care and telehealth. And in addition, I am a director of digital health for American Medical Association, where we work together creating digital health and technology as an enabler rather than a challenge to physicians.
I'm Krista Demos, founder and president of WellScent. WellScent is a startup that is working with UC Davis to translate a lot of innovations in healthcare to get them into people's homes. We're focusing mostly on caregivers and on peripheral devices and a digital platform.
Wonderful, thank you. So we'll start with one of the questions that basically has led to the movement being so big in care at home, and that is the tailwinds we've had from a regulatory and a reimbursement standpoint. Diana and Vimal, I'd love to hear your perspectives on what has happened in the last 2 to 3 years to give us that kind of tailwind and that energy behind care at home models, and then what do you see the future of those movements being?
That's a great question. I think we have all lived through the pandemic, and we know how the care has changed significantly. And previous panels have talked about that telehealth existed for a long time, but it was adopted during that time. But at the same time, I want to just share a story. My previous institution, we went through during the pandemic. We did not know how many patients are going to be admitted. Our ICU beds were kind of very, very limited. We were not able to provide care because of the mandate to close clinics and to decrease infection rate. And there was no other way rather than going to the digital health and thinking through and creating some innovative models. During this innovative model, we kind of thought through this whole continuum care journey and how can we fit and think through new care models which would support the patient and provide very high quality care. One of them around transitional care, where we were able to discharge patients much earlier than discharge, and we also launched care at home and hospital at home at my previous institution as well. So I think there is lots and lots of learning we did during the pandemic, which is unfortunate, but at the same time, we are seeing a lot of changes, and I think we are all working towards creating that new vision of how do we integrate care together so it's digitally enabled care across virtual and in-person, and we are not leaving any patients behind, any person behind.
I think also some of the tailwinds that we're seeing now, and it was pointed to earlier today, specific to the omnibus passing, the $1.7 trillion, and the PHE that was a part of the pandemic that enabled care to be home, enabled care to be billed from a Medicare perspective, and that getting a lifeline for 2 years. And I recognize that that isn't enough, but certainly that is a lovely tailwind for us to ride off of, to deploy these type of programs at home. And what we're seeing when we walk in the homes of people is them getting better and them actually being with their families and being with their loved ones and getting better food. Sorry, I'm sure your HCAP scores say one thing, but the reality is getting better food and being closer to the ones they love to get better care. So tailwinds from the omnibus package is great. That isn't enough. In the state of California, you have some hurdles to overcome for sure. And companies like us at Best Buy Health are working with CMS, are working with the federal government, working with our senators and representatives to make sure that we actually get funding for programs like this on a more long-term basis, because a lovely tailwind of 2 years goes very quickly. I mean, it felt like the pandemic started 2 minutes ago, but that was 3 years ago. And so we need better things to be in place systemically, continually, to make things successfully go forward.
You know, and I want to add, telehealth also got extended for 2 more years, and I think I want to invite every one of you to show the outcomes so that this sticks. That care models, we are creating new ways of delivering care. We need to show that from experience point of view, from access point of view, from operational and outcomes point of view, it is the value we are creating for our patients, for our clinicians, so that we can all succeed. So there is a lot of learning, there's a lot of research going on, and I want to invite every one of you to kind of participate and help us sustain this new delivery model and new ways of caring for patients.
I love that segue to my next question. So my next question is, what are some examples of outcomes that each of you individually, as part of your companies or your experience with your clients, have seen that sort of get you excited about the fact that these care at home models are here to stay? So Perry, if you want to get started.
Yeah, so we experienced a lot of growth in primary care space. So we really targeted, private clinic. We felt like as a startup going after the health systems, which is great, but just like I feel the sales cycle was a little bit more challenging and the diligences, and we feel like focusing at the moment on private clinic will give us the instant response on when the doctor is the CEO and he makes a decision on the spot. So number one thing we say, okay, how do we make the provider actually making more money? How is increasing his revenue? So ideally, we looked at what the limitation of the physical location. And we literally were sitting in primary care clinics and looking at the workflow. Okay, so they got the wait room, 5 people, then front desk, fill up the form, and we see there are a lot of steps just to buy more time so the doctor can manage to see everyone at the end of the day. So he will go to front desk, come back to the vitals rooms, and then from the vitals room, we'll go to the doctor, 15 minutes maybe conversation, and then go back to the waiting room, back to the front desk, go to the pharmacy. So how do we shift all that to the cloud? And we literally were sitting and built, some of it is an AI embedded tools that allow care teams to really build an engine of conversation with each other, communicate with each other, and we pull the insight to the billing department. But I'm just gonna go back to the visits. We managed to increase visits by 200%. So the amount of visits increased per day because we got rid of the wait room, we got rid of the vitals rooms, we moved everything to the home. We built a home clinic, 1 kit sent to the patient home, everything set up to go, and then everything down to the workflows. And number 2, we really managed to increase the patient per panel. So when we stepped in, an average private clinic had 1,500 to 1,800 patients. Today we're talking about 3,000 patients, and without adding even 1 desk in the office or buying another computer. I can go on, but I'll respect the panel, and I'll just maybe one more thing is they hire more people they hire more care teams without worry about finding them in a local neighbor, like in nearby, because they don't have to come to the office or the clinic. So now we got care teams from Florida supporting patients in New York as long as they're licensed in New York, and the cost even drop. So a lot of financial outcomes, and then of course, the clinical outcomes as well.
So specific to, and I'll just tie this to what Ashish was saying earlier this morning, clinician time is really the ROI that we need to target, and making sure that they are being as successful as they can in terms of the utilization of their time to enable a bunch of things to happen within a health system. So that being said, what we've experienced with Baptist Health, for example, is readmission rates that have not just been reduced to 0 for 30 days, but 0 for 60 days and 0 for 90 days. And that's pretty profound for the patients who are at home. So people aren't bouncing back into the hospitals. You guys are getting paid for what you need to get paid for, and you're delivering the appropriate care alongside us. So that's been super powerful. We also have offerings, commercial offerings in the UK as well, and 140 patients on a program at home, so a hospital at home program, or as they call it in the UK, the virtual ward, and yes, it's a different system, I get it, I live here. But what they've experienced on this 140 patients in a monthly period is that they saved 157 bed days, inpatient bed days. That's time, that's the ROI to your clinicians, because they're using their time thoughtfully. There's not a huge burden of data just coming over the barriers for you to act on. So those are just 2 data points, and we have so many more, whether it's more qualitative insights from patients in their homes at NYU, another large teaching facility, where patients are happier to be at home. The interface with the technology is easier, and yes, I'll talk about that later because she teed me up for that earlier. But just being as productive from a physician's perspective and as a person in their home's perspective, and we've demonstrated that with our customers, UMass Baptist across the pond too.
Well, Kamal, I think this is a fantastic question. I think without the outcomes, I don't think we should be talking about any kind of intervention. There's a lot. If it is okay, I can talk about model of what care at home means, right? And then probably go a little bit deeper in outcomes in each section. Is that going to be okay? So when I'm talking about care at home, I think about the 4 buckets and maybe 5 buckets, depending on if you're talking about the care, end of life care as well. So 4 buckets, and if you think about this, it's a very care continuum model. Starts with ambulatory and chronic care. Here is your primary care. Here's your oncology care at home. Here is your diabetes care at home. Here is your hypertension care at home. Here's your simple chronic care at home, population health care at home. Huge market. And there is a lots and lots of outcome which we can kind of think through. The second component to this is mostly on-demand care. Here we are talking about mobile lab at home. We are talking about radiology at home. We are talking about care at home where you can do urgent care at home. And UC Davis Health is right now looking forward to creating this kind of a model where we have express care, which is a virtual care, but we are also integrating directly at home care. When the patient is in need, when the patient is decompensating, we can send a complete lab, a person at patient's bedside who can take care of the patients and prevent that emergency department visit for the patient, because that's the most vulnerable time for our patients when they have to pick up the phone, they have to call the taxi, or they have to go to the emergency department, wait there for hours and hours. The third bucket, which I place care at home, is our transitional care at home. You're talking about here bridge clinic, from emergency department to the at home, from reducing length of stay, from discharging patients maybe a 2-day early. And I'll share some of the examples there, and the return on health, which I think we talked a little bit about. How do we create a balanced scorecard where we can see the outcomes in each categories, what we care about as a clinician, as a patient, as a physician, as a health system? And how do we then think about kind of creating those models? And then fifth, which I refer to acute care at home, where many people talk about hospital at home, but I really think this is the acute care at home, and the complex care at home, which is the end-of-life care at home with the social determinant of health needs and others. So I'll just give 2 examples for each spectrum here. Example 1 is chronic care. And this is from my previous institution where we implemented diabetes and hypertension care. We were able to and save 21% on medical cost. This was for our employees. In the other models, what we tried to do is try to understand how can we create an interdisciplinary care team who can then leverage with each other where they're practicing at top of their license, so that we decrease the burden on the clinicians and physicians and increase the capacity. And this is from an academic medical center where it's really hard to make changes. And we were able to show that we were able to increase endocrine physician new patient intake by 48%. We were able to show that hemoglobin A1C dropped to 3%, which is one of the markers of how good your blood sugar is controlled for 3 months. These are real world examples of how we can change the care model. How can we create digitally enabled care model where we infuse technology, work with and in synchronous augmenting the power of the clinicians to really care for the patients here. The nurses were working, pharmacists were working, and then physicians were working top of the license. They were able to see more patients. We were able to save more money. We were able to show return on health significantly in terms of experience, the understanding of the patients, how well they understood diabetes. And every time we got the best, CAP scores, like, this is fantastic, we want to do more. Many of the patients who was supposed to be terminated in 3 months, they wanted to extend it to 9 months. So fantastic there. I will go to the other spectrum, which is transitional care management, where during this COVID period, we had this surge where ICU beds were really, really in scarcity. Our inpatient beds were really in scarcity. Our modeling showing the infection rate was so devastating to our C-suite. Is like, how can we manage these patients? We launched a remote patient monitoring program, which was a part of overall transformation of the care model. We had the idea for a long time, but for one reason or the other, we never implemented it. Now we were able to kind of directly work with our hospital medicine physician, our surgeons, our other physicians who are admitting patients, and ask them, you know what, we have 24/7 RN for you. We will discharge you with equipment which has remote patient monitoring for your blood pressure, your temperature, your glucometer, your and you can call anytime because we are connecting. We are there for you. Guess what the outcomes were? We were, for the pilot we did, for 1,500 patients we discharged, we were able to decrease length of stay by 1.5 days per patient. That is huge. We were able to decrease readmission for 3 Vision category, sepsis, CHF, and respiratory infection, by 15%, from 24% to 12%. And the net saving after increasing the FTE to 8 FTE, we were able to, for the small group of 1,500 patients and very small period of time, net savings were $1.4 million. So I just kind of gave you 2 examples of 2 different spectrum, and I have, implemented that across the hospital at home. There's so many savings and so many ways we can really impact not only patient experience. Our NPS score was 95%. So this was a fantastic win-win for across the stakeholders, from the patients, for the health systems, for the physicians, because physicians are like, oh, I'm really enjoying doing this, because now I know that I have a care team who is going to be able to take care of it. I have an agreement with pharmacists who will increase their insulin 1 or 2 points, depending on what we came together as a care agreement. So this is a fantastic way, and I'm giving you a real-world example of academic medical center that we were able to change this, and this is just the beginning. This is the tip of the iceberg.
We are most excited about a much larger general trend, and that is how many people, especially over the age of 55, believe that the quality of care delivered remotely can be as good as that delivered face-to-face with a physician. And I'm sure that everybody in here is convinced of that, but a very large swath of the population was not. And to see that shift, and to see people that, not just in the people that we study, but really in our own lives, at the beginning of the pandemic, there was a study done with the VA, and they asked those receiving care through the VA what they thought of telehealth. And now telehealth in this study also included phone calls, but those who really thought highly of it felt that they were getting the same quality of care. Those who thought that it was worse looked at it as if they were being treated as second-class citizens. They said, oh my goodness, nobody's paying attention to me, my doctor just called. And so now, especially with older adults who are not, maybe not be the most technologically proficient, they are seeing that their quality of care is able to go up. And it's going, just to build on what we were talking about before, post-operative care, and being able to help in caregivers at home who may not be physicians or nurses, but maybe they're an accountant or a lawyer or somebody who can read instructions, but they just need to be told they need to be helped. So to Ashish's earlier slide when he opened this conference, it said said it takes a village. Yes, it does take a village, not just to raise a child, but to care for all of us. So seeing the trend of people being more open to having these conversations, of saying, oh, you know what, I will FaceTime my doctor, I will talk, and I look at that as just as good instead of having to get dressed and take the bus and go down, or there's a concern about older people, especially during the pandemic, getting sick from the doctor's office. Somebody sneezes on you and you're a goner. And being able to have that care and to see the very profound shift is the thing that we're most excited about.
I just want to add something on it. So you mentioned that it takes a village to accomplish such a task. So this is one of the things that we're working on a day-to-day, is also to make this affordable. Because of course, if we had all the money in the world, we can probably live on the moon better than we live on Earth, but it's not executable because it costs all the money in the world. So one of the things that we're investing in is really on starting from the basic. I mean, think about if you do a hospital at home, you might free one room in a hospital, but now you have 5 nurses full-time maintaining these remote patients. So what we have accomplished? Okay, yes, we accomplished the results of a program, and some outcomes are great, but at the end of the day, it's cost more resources that we don't have. You're talking about 1 million clinicians in the United States to serve a nation of 300 million, where 48 million of them is considered as high-risk patients. So one of the things that we worked on is really how we, starting for the basic, and the focus was not necessarily on a doctor and patient's relationship. We really concentrated on the care teams. And we looked at how do we basically optimizing the time of each care team. And we developed, and this is what Clini is about. Clini is basically, we decided that we're going to try to eliminate all these multiple channel of communication between the patients. Some of them using Slack, some of them using Microsoft Teams, some of them just like reading each other's notes on the EMR. And what we have created is basically a communication tool that allowed to caregivers and the care teams basically from now on communicate only on Clini. And it's a chat groups with groups. You can transfer files. You can literally built into the virtual care platform. And at the same time, between all the routine conversation about their children, about their weekend, we also capturing a lot of interventions, chronic care interventions that done as by the way, and those are billable times. So we basically looked at how do we optimize each care team. So at the end, where they graduated of doing primary care at home, and then transitional care at home, then hospital and urgent care at home and everything else. So yes, we gotta pay attention to how much resources is dedicated to a hospital at home, because if it's not profitable, it's a no-go.
Can I just add a little different perspective on that, a different slice of that? So I think Vimal gave evidence about length of stay and how that can improve, and then we've heard earlier today about the workforce and the compressed workforce. And I think that we have to stop thinking about our staff, nursing, clinicians, whomever, who support that patient or person at home and need to be agile enough to shift. So when those 5 nurses that you talked about, when 3 patients go home, we need to shift them so that they can support people at home. And guess what? They may like it better than being in a brick and mortar setting. So I think that offering that fluidity, offering that capability for people to have options, whether they're in a brick and mortar institution, but can convert to swapping and supporting people at home, I think that's where the cool stuff happens. I think that's where the rubber.
And to mention your retail location, Best Buy, it's every corner. You can pick up the hardware, you can pick, those are huge things, right?
Yep.
Yeah.
So
Blue shirts for everyone.
Yes.
So if
She's going to end up buying all of us.
That's the grand hope. So I think by everything that you guys are saying, right, it sounds like it's the best thing, right? It's good outcomes, it is cost efficient, it is better for patient outcomes, and yet the percentage of health systems that have adopted all of this is in the single digits. So what's to give? Why are hospitals not? And the counter to that question is, in your experience, what needs to be true for a hospital to succeed in care at home models? So maybe
I'll go first.
Go
Yes,
first.
please.
I think that the biggest problem is no one knows where to begin. And you have you have the whole gamut of chronic care, everything from well-known issues from like heart disease and diabetes to very, very rare kinds of cancer and other very rare conditions. So when people think of care at home, they don't know where to start. They don't have a, do they need to start with peripheral devices? Do they download an app? Where do they even start? And so I think it's very difficult because if you look at a lot of provider apps, they have wonderful apps where you can just go on your phone and you can have a visit with your doctor. Well, that's fine, but that doesn't include all of the peripheral sensors that you need that Perry's been talking about. There's so many different pieces. You have the clinician piece, you have the emergency care piece. Something's wrong, somebody had a procedure and maybe the stitches came undone, or you need emergency assistance. But oftentimes you have chronic care that you're managing. And how does that work? How do you integrate fall prevention? That's not a healthcare provider's job, but how can you help advise your patients and people, maybe put some amber lighting on the way to the restroom or give them some other suggestions on how to live, but that isn't exactly what a doctor's supposed to do. You're not sick, but you want to make sure that your patient doesn't fall and break their hip and really, become much sicker from that. So I think that the biggest problem is nobody knows where to start, and it's difficult because it's not a doctor or a clinical provider's job to be a salesperson. They're just trying to make sure that this person is getting care, and it's such a multifaceted issue that it's not just the clinician's responsibility.
So I'm speaking from insider's point of view, having implemented this many care models at my last institution. And very interestingly, we can kind of think through this, but I think the most important thing is the incentive. When I start thinking about, are we incentivized to care patients where they are? The problem is measurement. Are we measuring what matters? What are we measuring? Are we measuring the money? Are we measuring the experience? Are we measuring the outcomes? I think we're measuring all of it. How do we measure? Is there a single framework we are thinking through so that we can measure and show this is what the outcomes is? If you go to the CBO office, you would say, hey, is it cost? Is it increasing the cost or is it decreasing the cost, right? But it is not about, the healthcare is not about only money. It is about return on health. It is about all the domains we talked about. So I think the first thing is measurement. How do we change it? I have had experience and I've had opportunity to talk to lots of great leaders around, and I think everybody agrees that how do we start thinking about developing those financial models, the clinical models, the financial models supporting the clinical models. And I think we heard in panel today about how we should be thinking about value-based care models, but at this point of time, 99% of the hospitals and health systems are still in fee-for-service model. So how should we start thinking about valuing for what matters for our patients? I think that would be a great thing. Then operational and the workforce issues. We are not trained to think about a patient as you were talking about. We are not trained as physicians to take care of the patients at their home. We are, at this point of time, most of our residency program teaches providers, physicians to train in inpatient setting. And we are saying, hey, let's care for our patients at home. So we need to start thinking about the education, about the training of the physicians, our next generation clinicians, so that they can integrate through this. Majority of the hospitals and health system academic medical centers don't even have telehealth curriculum integrated in their curriculum. There's no digital medicine integration in their curriculum. So we are talking about that, yes, there is a huge opportunity here, but our way of training our workforce continues to be lagging behind, and it's not following the trend as what the needs are. So how do we bridge that gap of financial models, which will support what is needed to be done and support the return on health framework so that we're measuring across as a balanced scorecard? The third thing which I will certainly bring up is we are, as a framework, this was exactly when I also work with American Medical Associations, and I think Meg talked about this. When we were doing a national kind of survey of different institutions, we asked this question, asked this question as, what does a care at home means? And we got different answers. So everybody is going towards hospital at home. Everybody is going towards acute care at home. I said, in 1980s, 1990s, we have independence at home models, which were created. Right? There are so many different models which already have proven that they work. How do we integrate and create a single vocabulary when we talk about care at home? What does it mean? How should it be delivered? How should it be financed? And how should we measure outcomes?
Totally agree. Well said. Where can I riff off of you? Specific to...
So Dan, if I might, if you want to flip that and tell us, if companies are approaching health systems to sell, given that such few are actually engaging in these models, what makes a health system a better candidate for care at home programs?
So I just to finish on that, and I'll jump into that. So
No, she got two answers.
I get
That's
two
good.
answers. Yay! So what I would say is on the earlier question and what you were teeing up is that we somehow did it during the pandemic. We somehow actually, everybody in this room had a telehealth visit. I did probably twice. We somehow did it, and keeping that mindset present of what we can do differently and constantly looking up and looking out and saying, you're absolutely right. We're training in this one way, and we have to stop training that way. We are delivering care in this unilateral way, and that under every door and in every window, there's an opportunity for us to think differently about how you actually care for people at home, and we just need to try. But yes, there's an infrastructure, and yes, there has to be an ROI model, and yes, there need to be use cases that pivot, that say, yeah, this PMP that's in hospital to transition a patient into a step-down unit or even going further down the food chain, as it were, and within the brick and mortar, does that work? Let's take the best parts. What's the experience that we're trying to get in the home and work backwards? I've been in homes where there are hoarders in there, and we've had to clean their homes to make sure that a person can get to the bathroom at night. That is stuff that we don't contemplate when we deliver a care at home program. That just needs to be done. And yeah, it's a little challenging, but we can do it. We did it. Let's keep going. Let's keep that momentum going. We can do it. And you have companies like Best Buy Health and other companies out there that have plug and play use cases that you can test and say, does this really fit in? And let's tune it, and let's twist it, and let's make it work for our patient population. So that was the first answer. Okay. The second question is, where does it work? In academic medical centers and large teaching institutions. It works where people are thinking about their entire patient population and not just worried about the people with money. We have to be serving up places where, and particularly at UC Davis, and particularly in the California system, where there are rural pockets that, regardless of your socioeconomic status, that we as working in collaboration together can reach that patient population. And so it works when people are progressive thinking and want to try something new and can see a model. And we also need to take into account that when somebody ends up in an ED and a physician can make one click to do an inpatient admission, and it shouldn't take 6 clicks in Epic to get to a care at home setting. So being really thoughtful and saying, it's a pain in the noodle to do this. What are we going to do with our Epic system? What are we going to do with our own care teams to make sure that we can try the model at home, that we can be successful to get all those wonderful outcomes that you had? I'll shut up now.
Before I let Perry answer the question, I just wanted to flag, we'll open it up for audience Q&A, so if you guys have questions, keep them ready, and then as soon as Perry's done, we'll open it up.
I'll keep it very short because assuming I'm also covering mainly the technology and the product side, because I'm not, I didn't come from the clinical side of the business. 20 years in healthcare IT, I only done on the technology side. I started in skilled nursing, and now I'm moving to care at home. So I just want to say one thing that I witnessed from probably the most objectives I could be as a tech guy. Try to humanize the technology, and I'm going to connect to what makes health system as a good candidate. So one thing I witnessed is when we, at the beginning, chasing how do we deliver care to the home and give and I'm going to go back to care teams because I'm in love with them. They're just going through a lot, and I explain. Huge burnout. Really, a lot of care teams suffer from burnout because we make it accessible. Because technology now is make it not just going to the hospital, do my shift, and go back home, be with my family. Making care virtually, making care teams working more hours. So one of the things that at LifeCare, using Clini, is how do we humanizing the technology, not just to be accessible, but also manage the care team schedule and triage tasks to avoid and reduce burnout. What makes a health system a good candidate? I didn't work with many of them, but I can tell you one thing I witnessed, again, from the Silicon Valley side, is the health systems are trying to uniform everything, and everything is a template. So we found that what's good for doctors in Nebraska is not what's good for doctor in New York, and same thing with the patients. So some large health systems, and yeah, I'll take the risk and I'll give you even one of them, like Ascension Health. So the clinics in Michigan were completely different than the one in St. Louis, and health systems come with the mentality that everything has to sit on the same umbrella. So a good candidate for health systems, at least for LifeCare, is ones that are open to understand that we're living in a very diverse states society.
That's awesome. Thank you all for those really enlightening answers. I want to see if there's any questions in the audience. Okay, there's a couple hands.
I'll do the front first before I run all the way to the back. Being lazy, sorry.
Thanks. I was curious about the patient side of the equation. Do you think patients are ready for care at home models? Taking an example, maybe a bad one is we order food in, and I would much rather prefer a restaurant experience to dining at home, and patients probably feel more comfortable in a hospital setting where they know that they're going to be catered to, even if there's shortage and stuff. So what's your perspective? Have there been any surveys where people have been open to care at home versus being treated in a clinic or a facility?
Maybe I can try to answer that question. So the fantastic question. So I want to make sure, as we're talking about, this is a continuum of care which ranges from really healthy, lifestyle wellness questions or models to really acute care models. So there's a huge spectrum and huge number of patients. With that, we need to make sure that our criteria of selecting patient is very robust, because it's the right patient at the right time with the right care with the right team by the right provider. So those 5 right has to be the right modality as well. That has to be mashed together. So it's a precision medicine, and technology has to be precise in terms of you don't want to invest in the most integrated and with massive expense remote patient monitoring equipment, who we are doing it for acute care at home versus when you are doing, bring your own device with, diabetes management, right? Which you can get at $50 on CVS. So you need to really make that, or Best Buy.
Only Best Buy.
Best Buy. So you have to really calibrate and do this is a precision medicine, digital medicine 101. It's a huge opportunity for all the clinicians who are getting trained as to how to do that. And the second point is, yes, our experience, this has not been done so often right now that you can say that I got a bad food today, but it's the reputation of the health system who's providing care as well. So I don't think anybody would try to first select wrong patient and then provide bad care. If you see across the studies, Australia, UK, and in United States, the experience of a patient is fantastic, but you don't want to choose a patient who has no support at home, or you are burdening the patient's family members to take care of the patient. So you have to be very careful. You need to have social determinant of health conversation, understanding of the structure, because that patient clinical need might be taken care, but maybe the socioeconomic needs might not be, and that might not be a good fit. So I think I just want to kind of talk about this as it's a very customized care for the patients, and it cannot be just blanketly implemented.
Thank you. Ritesh? Second.
Oh. Hi, I'm Rachel. I'm the CEO and founder of Musical Health Technology. So we have a digital health platform that uses singing as a therapeutic tool. Sorry, I just came from CES, so I'm a little hoarse from shouting over everything at CES. But so we use singing as a therapeutic tool to treat a variety of healthcare conditions, including dementia, depression, in older adults. And what I've found is that we've gotten much more acceptance and traction in the UK because of the socialized health system than we have in the US. And I missed the beginning of this, so if you guys have already talked about it, I'm sorry, but you know, they talk about like quality of life adjusted health years and all of these kinds of things. And so I'm wondering, when you're thinking about these things, because a lot of times, you know, as a startup, it's hard to prove that ROI in America. But in the UK, you just really need to prove that you can provide more, better care at a lower cost. And if you can do that, then you get through some other things, the NHS will pick you up and be reimbursed. But here, it's so hard to do that. So are you looking at those kind of models that are sort of a more socialized model to solve some of these problems?
So we have a business that's in the UK. We actually started in the UK with our current health offering. And it is easier because they have been super progressive in terms of virtual wards at home, fully funded virtual wards at home, and that's been going on for several years. And they have a milestone to meet that. I think it's something like 25% of their beds have to be in home by 2025. So that is their goal. They're falling a little bit behind on that goal, but that's what's happening in the UK. The UK also has been doing early warning scoring for years. I mean, so they just are a completely different model. But I will say that in the United States, we've been doing care at home since 1970. And we've had funding in the federal government to do care at home since 1970. And whether it's on, you know, renal care, or whether it's on diabetes care, or primarily in the veteran space, that's what we've been funding. So let's remind folks who are giving you the Heisman that it's been going on for years. Has it been as aggressively funded as it's been in other countries? Not so much, but just a little reminder of that. That's all I would say on that front.
And I'll just add that we have not invested in healthcare intervention and healthcare delivery, innovation and assessment as much as we have invested in, you know, other parts of NIH. We should be and thinking about, because this is a healthcare delivery problem.
One more.
Hi, I'm Vinay Bhargava. I'm co-founder of Mytonomy. We're a video-based patient engagement and education company, and UC Davis's newest patient ed vendor. Health at home, I think, to the typical American consumer might sound confusing. How are you explaining the nuances of the devices and the data and all the protocols without driving up like CRM costs for your nurses or whoever's in charge of that?
I'll take a quick one,
Yes,
really
yeah,
quick.
go for it.
The goal of enabling care for us is that we don't deliver care. We leverage great places like the UC system and any other health system to support that. We do have social determinants of health offerings through calls back so that we can cover that. We can do a first call. But the technology and working at the top of your license is really important. And so we recognize that. And with the acquisition of Current Health and then combining Best Buy Health with our omni-channel presence and our logistics that are expedited into the homes, alongside Geek Squad, so somebody's not hanging a TV in the morning and then showing somebody how to use technology, but we're in there in people's homes, making sure that the Wi-Fi is up and running. If their Wi-Fi is not up and running, then making sure that our cellular hub can work for them, teaching somebody how to use, and yes, in their 80s, and yes, like my mom, how to use the technology so that it can be just forgotten about. You ease that burden, you take it off of the mall who's on the other side of the telehealth visit, where he may be spending 50% of their time or 75% of their time training on tech. That's how we've solved it. Getting people in the home across the threshold, not just dumping a FedEx out in front of somebody's house, to make sure that the tech's working, the connections are working, and then if there's a fallback, if there is a problem with the technology, we can have somebody call in or prompt somebody through a tablet to say, hey, tech's off, battery's low, things like that to make it easier for the patients at home.
And I have a very simple answer: creating an easy button. This has to be integrated with the care delivery. It has to be. If I am sick, I press an easy button, health system figure out how do I deliver care. That's my role. So I think creating this, like, I need care at home, I don't think is the right question. I think, how do I care? How do I get care? And where I get care, we should be, as a healthcare provider, ready to deliver. And an additional thing, we are actually, framework-wise, I kind of talked about it, we are creating a health at home framework, which will be out in January, February. So it will talk about the frameworks around and what we have learned from industry.
One more question.
Hi. My name is Murli. I work for a local FQHC here in San Francisco, and we serve Medicaid and Medicaid patients, low income and elderly population. My question to you is more about what are some other care at home technologies have you seen? You know, what we are facing very realistically is serving a monolinguistic, elderly, culturally sensitive, technologically completely incompetent in Silicon Valley. And I'm using it in a very sensitive way. I don't mean it in a bad way, because I have 12 grandparents at home that do not like technology. And when you are sending them home, and it is great, and I have been providing for my dad since 1975 care at home by driving with him behind the scooter in India. And as you rightly said, since 1975, we have care at home. And we are struggling here because when I send for a hypertension patient with a diabetes, it's a comorbidity. I have to give him a blood pressure, I have to give him a glucometer, I have to give him a pulse ox. And then I'm expecting he or she to say, wear it like 2 hours at a time, and then I'm gonna have somebody call you, and I have to figure out interpretation services. So you see all these barriers. Mm-hmm. So it's not the intent of the health system is bad. Health system wants to stay, but we have a consumerism issue here. Healthcare as a consumerism, right? And even if we are trying to democratize the information, democratize the care, we have resistance because we are seeing as somebody said earlier, we are putting labels. Oh, Ritesh said, right? We're putting labels, digital, health, care. Why can't it be just saying, Dad, I am caring for you?
Okay. Do you mind? Okay, so this is just quick. So, sir, I spoke earlier about the smart home medical gateway that we designed. So when we built our platform, we just were shocked by the amount of how many peripherals are out there. And those who came from CES, gazillions of wearables. So you walk into CVS, you walk into Walgreens, Walmart, there's aisles of peripherals. So it took a year, but we built a smart home medical gateway called the Link Plus, which is basically a device that we decided to stay peripheral agnostics for the reason that I just mentioned. And we just developed the hub that basically scans the house all day long. You open 2 networks, one of Bluetooth and one Wi-Fi, scans the house all day long. And we literally, no joke, we went to every one of those retail stores, CVS, Walgreens, Walmarts, even some of Amazon.health, and just order all the peripherals, over 100 type of peripherals, and started to understand the Bluetooth protocols and those who are looking for Wi-Fi. Today, and I think you got some samples, right? So today,
They're really cool.
yes, today basically all you have to do is just put the Link Plus at home, and every peripheral you're using, either you go on a scale or using a glucometer, not provided by the care system, it could be provided as well. But you're gonna go to CVS, buy any AccuCheck, or buy any blood pressure. You come home, you use it, the data is in the cloud. 0 pairing, no multiple apps. So that's at least our contribution to the problem. Go ahead. To the solution of the problem.
I just wanted to, I'm so glad you asked this question because it's something that we've run into where you have a myriad of sensors. And I will say a personal story. We bought my mother-in-law an Apple Watch because her doctor recommended we get it. Well, it's been charging for 14 months. And so every time, oh no, it's charging. I said, well, it was charging last year when we bought it for you. And so you make a very, very important point that we can invent all of these wonderful things, and if they don't wear it, they don't wear it. I mean, my dad also had an Apple Watch to take his EKG, and he came in and he was so frustrated because he just wanted to see what time it was, not what the weather was in Cupertino, or he didn't want, the stock market at that time. He just wanted to know what time it was. So there really is that personal aspect. And I'm really glad that you brought that up, because that's something that we are at WellSent, and I know Perry's working on that as well, trying to get to the human side of all of this, the human care, the fact that when we talk about patients, to Diana's point, they're not patients, they're people. They're mom and dad and brother and sister and aunt and uncle, or your husband or your wife, and if your loved one. So many people are in denial about the conditions they have. They don't want to talk about the fact that they have heart disease and diabetes. But if you want to talk about their husband's diabetes and heart disease, oh, they will order everything, but not for them. Oh, they're fine. They'll just walk it off. And it's really, it's important to remember that we're serving people, and people in all of their myriad. And then when we talk about caring for them, it's also helping understand that maybe they don't want to be bombarded every day about their chronic care. Maybe they are afraid or upset or don't want to be burdens, but always remembering who it is that we're serving and all of the myriad of things that we go through. So thank you very much for asking that question.
Very well said. I think I can totally relate to what you're talking about, and I would actually also counter that, health at home or care at home started in 1970s. I think it was the inception, how we cared for our patients at their home. That's how the healthcare started. So I think we are going back to the future rather. And the question is not about, what patient needs, it's how do we make our offering so flexible that the patient needs, as somebody who is challenged, vision is an issue, hearing is an issue, we have those patients. How do we connect to them, to our health system, and provide the personalized care, the precision medicine care, so that we are not just throwing gadgets at them? I think technology is not a barrier. It is about how do we care for the patient and really create an ecosystem of care which is flexible and very personalized.
I think you got plenty here, right? Good.
Thank you for that. We'll take one last question.
Hi, my name is Archana. I have spent 2 decades, almost 3 decades, in the oncology area, having worked in the pharma and biotech side. When I think about oncology, 80% of those patients are actually residing in the community and rural settings. So my question to the panel is, care at home for an oncology patient, depending on the staging of the disease, of course, the age of the patient, and the socioeconomic determinants of the patient, not just for the United States, but also globally when we think about it. There are very unique unmet needs. And how are healthcare systems thinking about that and planning for that very specifically for these oncology patients in those settings? Thank you.
Thank you. Bimal, you want to?
Yeah, this is a very wicked question, right? It's a really hard answer, because that's what we're alluding to, creating a very flexible model of care to the needs of the patients, and purpose-driven and problem-driven rather than technology-driven. So I think there's a lot to learn. Oncology is a great site, and there's actually lots of, there are 50 grants which were just offered recently around understanding those needs. So there's a lot more coming. I don't think there's a single answer. But for example, we created at-home lab services for our oncology patient, for neutropenia patients after they had the chemotherapy. Many of the patients who come to the office, they get the labs and they are neutropenic and they cannot get the chemotherapy. That's a waste of time for them. This is inconvenient. They might get infection sitting in the waiting room. So there is a lot more we are doing and thinking through it. What is needed, how it is delivered, how can we create the fidelity to really encapsulate the needs of the patient. So a lot more coming. It's a very exciting field.
And there are plenty of examples of oncology programs in care at home, whether it's through pharma and research that way with remote clinical trials that are at home. We work with Vanderbilt today on their CAR-T program, specifically caring for oncology patients at home. So they do exist, but I totally agree with you that it has to be specific to that patient population, and what the goal that you're trying to achieve with the care at home.
Thank you.
Thank you.
Well, with that, thank you so much for the active engagement. I want to thank the panel here.
Thank you, Dr. Kamal, to you for putting this together. Thank you.
For a really invigorating discussion. And thank you all for being here. Thank you.